Probably one of the best, if not the best, breast cancer specialist in the region. He had a long-term training in Canada, and now he is the chief for the breast cancer unit in the King Faisal Center in Saudi Arabia. Dr. Tahir, of course, is heavily and effectively involved in basic research and translational research. His talk is addressing the signaling pathways and acquisition of resistance to endocrinal therapy. Dr. Tahir.
Thank you, Hamdi, for this introduction. I would like to thank the organizing committee to give me this opportunity to present this data. At the same time, I think that it is a challenging talk in the way that after 150 years of using target therapy, maybe the first one was oophorectomy. It is still behind, and maybe the first time, and even for the most of the seniors here, they will know that we are working on very small subset of estrogen receptor where the targeting is, and not more than 6 sites, as you can see. And this is the challenging that maybe we don't understand more the estrogen receptor. I am lucky that they give me 25 minutes because this talk is supposed to be for 40. So there was a dialogue and discussion, and finally it will be 25 minutes, and I know it will not be enough. Now, let's share with you first thing that the hormonal therapy of breast cancer, majority of the breast cancer, about 70% are estrogen receptor positive. Endocrine therapy are effective in about half or maybe less. Resistance can develop more than 10 years after the diagnosis, and we learn now from the Lumina A and Lumina B. And late recurrence may represent slow growth, tumor dormancy, outgrowth of subpopulation, and development of acquired resistance. Today, we are going to tell you about all of this. Look for this. This is the meta-analysis that we believe in it. It has been published in Lancet 2011. And recently, about 3 months ago, there was an update on that. Basically, what happens here, as you can see, 47 of patients, they don't need a treatment, and we treat them. As you can see here, absolute benefit, about 14% between the control and the one that received 5 years tamoxifen. And again, recurrence in about 35% of patients, in spite of treatment, primary or acquired resistance, we need to understand. So this is a fact that we are treating with tamoxifen, we're treating all of this. Still, we have subset of patients that we don't know how to deal with them. Now, as you can see here, maybe you can concentrate on the other one there. More than half of breast cancer recurrence or death occur post-tamoxifen. And everybody that in Boston, Antonio, and this year, this is another issue. 5 years, 10 years of tamoxifen, 5 years of tamoxifen, 5 years of aromatase inhibitor, and so on. We start in the stage of learning, but this is a fact that still patients relapse and die from breast cancer. Interestingly enough, this is a very good data. This is since 1996, but remember, at that time, the immunohistochemical staining for ER and PR was not optimal. Still, we are learning a lot about that. As you can see here, still at 12 years, there is a number of patients, both in ER negative and ER positive, still relapsing and have distant metastasis, or they die from the disease. Now, in the era of the gene expression analysis, we start learning, as you can see here, ladies and gentlemen, about 2 different subsets of which is called the dissection of the ER. And the dissection of R, now we have a Lumina A and Lumina B. Yesterday, there is one of the speakers, they give us very nice slide on the dissection of this group. And I think that I strongly believe that Lumina A and Lumina B is not one disease, it is multi-diseases, and I am sure that in next few years, we will dissect this group who is going to receive the right treatment. And again here, if you are looking for the two subset, even though ER and they are receiving treatment, there is a difference between the subset within the molecular. And I think that everybody knows that. So basically, this is another evidence that still we are behind for understanding patients with ER positive and how we treat them beyond the 5 years of tamoxifen. Now, the problem is resistance, and I am going to go to my topic now. 50% of hormone receptor positive breast cancer are de novo resistant to endocrine therapy. Number two, many cancers and all metastatic cancer develop acquired resistance to endocrine therapy. The mechanism of de novo and acquired are likely similar, but are not completely understood, and we will see that. A better understanding of the resistance mechanism will allow the development of a new therapy. And I think that myself, I start learning since the introduction of the mTOR inhibitor lately with Afinitor. This is open a big subject of research in the area of the breast cancer, ER positive, HER2 negative, and I am sure Dr. Matthew Apro, he will elaborate on that. But my job today to tell you where we are at the difference between intrinsic and acquired endocrine therapy, which is written in yellow. That means this is the way. For example, this is which is called activated protein activity. Recently has been shown that when it is increasing at the promoter, which is called the cyclin A and B response element, has been associated with the tamoxifen resistance, response to aromatase inhibitor, making them from primary to secondary. So when they relapse, this is the best group to go for mTOR, for example. And then we have the BIKT, AKT, and the epidermal growth factor, all of this, and then SARC. Okay, we will talk about this in more detail and understanding. Now, I would like to mention here, maybe most of you know or you don't know, the estrogen receptor alpha, there are 595 of proteins. In the last 150 years, we are able only to understand the six site of autophosphorylation. That's it. From amino acid 1 to amino acid 595, we have no information except about 6 sites of phosphorylation, and I will share this information with you. That means it is a sad story. In 150 years, we don't know anything. So this is number one. Number two, as you can see here, the estrogen receptor has been divided to AF1, which is called activated function 1. And then we have, which is called DNA binding domain. We have a ligand binding domain, or F2. I don't know, computer is not. Anyway, so this is what you can see here. Okay, so that we have AF1 and F2. What is the learning today from this? Now, all our problems in AF1, meaning between amino acid 1 until 263, and we have problem with AF2 between 302 to 595, where SARC is working. Interestingly enough, recently, we know that patient who is autophosphorylation through the protein 305 has been associated with the poor response to tamoxifen and respond to mTOR group. So this is information to tell you that all our problem between amino acid 1 and amino acid or the protein 263, we have a little bit of problem between 302 to 595, and this is the group, when they have a signaling through that, they have the best response to tamoxifen. They live longer, and they have a very good, durable response. And again, here to show you the difference between the two, between alpha and beta. And we are working at King Faisal to understand the mechanism or the difference between the two in terms of affinity, ligand, different in gene activation. So we will come to this soon. Now, I would like to share with you a very important slide for understanding our future for patient treatment. Here, ladies and gentlemen, we have which is here we have which is called the classical action. And I don't know, we need to use the arrow, but there is a problem with this old computer. It is anyway. Okay. So this is A, which is called, it is classical action. And you have to remember the classical action which is occurring on AF2. That means between amino acid 302 to 595. What does it mean? This estrogen receptor, as you can see here, the estrogen receptor here, estrogen receptor that it is binding, and they are looking for another molecule which is EER to form, which is called heterodimerization. This big molecule, they are recruiting important co-activators, and the most important one for the classical action at AF2, which is activation function, is the nuclear receptor co-activator 1, or which is called SRC1. We have another one here, which is called amplified in breast cancer 1 protein. Recently, the Chinese group has been shown when there is overexpression of protein 300 has been associated with the tamoxifen resistance, and this is the change which is called in co-activator factor. Now, after this complex, and this is co-activator, they go to which is called the promoter DNA, which is the name of it, estrogen receptor element. This leading to transcription, leading to cell proliferation, number 1, inhibition of apoptosis, number 2, number 3, invasion and metastasis. Assuming that we are giving tamoxifen, we suppress this phenomena. So this number 1, which is the classical action. The second one, which is non-classical action. Non-classical action meaning estrogen and estrogen receptor forming a complex, recruiting co-activator the same like classical action through Foss and John, and then they are going to which is called activated protein 1. This is a cyclin AMB response element. In our patient, we know that 20% of this group of patients, they go through this pathway, and all of them are resistant to tamoxifen. The reason for that, because they are overactivate or activating insulin growth factor, cyclin D1, BCL2, and so on. Now, the third one here, which is non-genomic, I will talk to this one in detail because there is a new data, meaning that the estrogen receptor in cytoplasm, not in the nucleus. So we have a two mechanism at this one at the nucleus level, this one non-genomic at the cytoplasmic level. The dangerous one in action is the ligand-independent action. Yeah, okay. Okay. Yeah, it is. Because this one, this is not working, the arrow is not working. Anyway, so the ligand-independent action, what does it mean in English? The ligand-independent action, this is occur, as I mentioned to you, in AF1 between a protein number 1 and the protein 263. What they do, the estrogen and estrogen receptor, they are binding to each other. They are looking for another molecular to form, which is called heterodimerization. They are asking for adapter proteins, and then they go for estrogen receptor element to do a 6 function. Who are these 6 functions? This is our life. Remember, guys, all your work on tamoxifen for the last 15, 20 years. Maybe Hamdi, he did this one for the last 25 years. Basically, he's giving his treatment, and then at the end of the day, out of 595 of amino acid and protein, only 6 sites for phosphorylation. They allow the estrogen receptor to do so. أي حاجة تانية, we don't know. أي شيء تاني, it is out of our brain, it is out of in the inbox. What we have here. We have here at the AF1, as you can see here, ladies and gentlemen, we have, thank you. We have a cyclin A and cyclin D1. It is only phosphorylating through serine 104 and 106. That's it. They understand only this. And the other one, which is the mitogen-activated protein, which is RAF, MEC, mitogen-activated protein, they are recognized only serine 118, AKT, mTOR 167, and then protein kinases, it is serine 236. And then, the mitogen, the B38, here the thyrionine, and then here yarine for the SARC. When the guy, Bishop, he given the Nobel Prize for SARC in 1998, when I start understanding the signaling, I don't understand why this guy has been given Nobel Prize. And now I learn, why this guy, he deserved Nobel Prize for the discovery of SARC. We will talk about that. So basically, as you can see here, all your work or your job for giving a tamoxifen, it is working at 6 sites, that's it. Anything else, we don't know. So as you can see here at action, so the estrogen receptor element, all of this, they are working in that way. Now, we know that the patient who is working through this pathway, serine 118 and 167, the best responder to tamoxifen. They live longer, response for a long time, relapse, give aromatase inhibitor, relapse, give mTOR, doing extremely well. We know that. I will show data that when you have tyrosine or thyrionine at 305 here, the poor response to tamoxifen, and this is the group should be treated with aromatase inhibitor or mTOR inhibitor. And we will show you data. So basically, the learning curve now, what you know, it is very small, AF1, AF2, 6 sites of phosphorylation, target, which is called gene targeting, it is only limited. Anything beyond this, from 1 amino acid to 595, we don't know. Now, and first of all, just to let you know here, that if you are giving the estrogen and estrogen receptor binding, as you can see here, maybe it is better to be seen there, as you can see here, as I mentioned, either through ER, this is a direct, this is which is called the protein-protein interaction on AB1, which is it is a specific protein, and then something which is through the genome, which is called non-genomic pathway. Now, just to let you know here, this is the area where the ER is located in cytoplasm, and I will come to this because this is the one that patient not responding to tamoxifen. Now, this is just to show you pathway associated with the resistance. We know that epidermal growth factor, we know that, AKT, mTOR is problematic. Now, this is the one that I would like to share with you because this is a very important study that when you have ER, you see here the protein kinases, when it is leading to phosphorylation of 305 at AF2, leading to poor prognosis. Look for 167, 118. This is the group that they are doing well because of the sensitization of the pathway, and I will show you something very interesting on that, leading to activation of BI3K, AKT, and then, mTOR. Now, so this is the difference between two. As you can see here, if it is negative tamoxifen benefit, here no tamoxifen, and all of them, they are working at 305. This is the most recent understanding for molecular mechanism of endocrine resistance. Just we have to take it easy to understand this because this is a new phenomena since the introduction of the mTOR. Now, ladies and gentlemen, we have 3 molecules. Nobody knows about it, maybe unless you are science. We have SASH. We have here something called SASH. Something very new, which is called MNAR. This is called modular non-genomic ER functioning protein. And then something we have here, which is called MATIS. It is metastasis-associated gene 1. This is the new phenomena in understanding of molecular resistance. How they do that? So as you can see here, estrogen and tamoxifen both can activate non-genomic pathway, meaning that this is the ER in the cytoplasm, it is not in the nucleus. Basically, ladies and gentlemen, so this one, they are recognizing or recruiting the SAC. The SAC this is adaptor protein. It is adaptor protein. SAC in turn go and activate mNAR leading to this pathway. So AKT, BI3K, AKT, mTOR. This is the group that well done on mTOR inhibitors. Now, then the importance of that, you see here that again tamoxifen and estrogen receptor, estrogen and tamoxifen and estrogen receptor. Recently, in 2011, we know it is working on the G protein coupled receptor. In fact, when they are activating this, they are upgrade SARC. Upgrade SARC, which is again another adaptor protein, leading to activation of matrix metalloproteinases, which is the 16th family, leading to cleavage of heparin-binding epidermal growth factor, leading to all these phenomena of signaling cascading. Insulin growth factor, epidermal growth factor, HER1, HER2, and so on. And this one, as you can see here, they go down, through BI3K and so on. What is the importance for understanding of this one? SASH always has eye on mTOR. mTOR, they have a sense of SASH is not doing well. So overactivation or recruitment of the cell of SASH leading to activation of AKT غصباً عن الcell. Okay? So here we have what is called metastasis-associated protein, increasing significantly the number of ER in a short period of time. They become thousands of ER. So it is hyperactivation of the cell, leading to activation of BIKT, AKT, mTOR pathway. So as you can see here, this is the outcome. And this is tumor production, endocrine resistance through all the phenomena of gene productions. So this is, I think, that very important slide for understanding what is the future for understanding adaptor protein and a couple of new, which is called mNAR and MATIS. Now, to make it easy for you here, as you can see here, if we make estrogen deprivation, what happens? Decrease proliferation, increase apoptosis. Look here what mNAR and MATIS doing, increasing the number of ER, making ER hyperactive. So basically here, activating the BI3K mTOR specifically, leading, if you have inhibitor, it's supposed to inhibit this, leading to increased proliferation, survival, and this is why mTOR inhibitor is a good in this pathway. This is a slide, it is really very nice one to understand the difference between activation of mNAR, SARC, cleavage, and then, all the tyrosine kinases family. So that means if you have the mTOR inhibitor, as you can see here, it will down-regulating all of this. The question, mTOR active in breast cancer? Yes and yes. And as you can see here, I don't have to spend a lot of time, but importantly, that the BI3K, which is about 21% to 33%, our data in Saudi Arabia now, we have 21% mutation in BI3K, and again, 30 to 4% of breast cancer cell AKT activation, and so on. I think that, the previous slides give you idea how the situation and how much the learning curve on the estrogen receptor, however, it is long one, but, our knowledge, it is limited to 6 sites of phosphorylation now. Now, this is the regulation of mTOR. As you can see here, it is BI3K, AKT, mTOR, how the protein synthesis and how it is working within the cell cycle. Interestingly enough here, how this guy, based on the data I told you about SAC and SARC, understanding the sense of the mTOR, when you are inhibiting that leading to do all of this. So downregulation of HIF-alpha, cyclin D1, protein 21, protein 16, BCL2, CMAC, and so on. So this is how it is working. Now, again, this is just a summary of the mechanism for all of you. If you have aromatase inhibitor, you know ER, and then you know change in coactivator. I think that it is clearly demonstrated on my slide. And the other one here, if increasing the signaling through PI3K, that the learning curve about the mTOR inhibitor, and then finally increasing the expression signaling through a different receptors from SARC and the G protein coupled receptor, leading to understand the phenomena of mTOR. So this is again, and this is how there is a drug, I think, that have a strong future in trastuzumab resistance. We are going to see a beautiful result. Maybe it is more powerful that it has been in postmenopausal HER2 negative. In conclusion, because of time, I think that I did well in time. Basically, it is, I don't think that we need a conclusion as much as my understanding for this. This is a phenomena of science. We are keeping up. I think that mTOR inhibitor opened a way for a lot of research, and myself, I learned in the last year a lot of signaling through this pathway. Thank you very much.
Thank you, Professor Tahar, for this elegant review. I have only one question. You mentioned the pro-survival pathway, PI3K, AKT, mTOR, and this is very clear as regards the value of mTOR inhibitor in endocrine resistance. For the other pathway concerning with the proliferation, son of syphilis, RAS, PRF, what is the role of this pathway, the proliferation pathway, in the endocrine resistance? Second one, is there any drugs involved in this pathway to overcome the endocrine resistance or not?
I think that is a good question, and thank you. Our learning so far, when you are taking the PI3K and then you know AKT, mTOR, okay, and this is a pathway we know that it is mTOR working in that way. Now we know that the protein 38 specifically, when RAS, RAF, ERK, mitogen activated protein, this group of patients, they have a resistance specifically which is called the primary resistance from day one, okay, for tamoxifen. We don't know how to deal with them. We don't have information that they are working, which is called the bypass to AKT again. There is no information on this. But as you said, RAS, RAF, ERK, mitogen activated protein, maybe we have to understand more this signaling. And in other way, I don't think that the mTOR inhibitor, it will give us a good outcome in this group.
In your clinic, you should differentiate between primary endocrine resistant or secondary. Is there a difference in your management?
This is Dr. Mati Abro. He's going to talk to us about the primary versus secondary resistance. Okay. And this is a big, I think, that outcome from, I mean that any of this we can discuss, this primary versus secondary, because now at the C6 side of phosphorylation, we know where is the primary and where is the secondary resistance, and I can talk to this about you for you guys.
Thank you, Professor Tahar.